Welcome back to the Deep Dive, where we deliver the most important cutting-edge insights from global research directly to you.
If you're looking for that shortcut to being truly well-informed, you are in the right place.
And today, we are diving deep into oncology. Specifically, we're looking at the new front line in the fight against resistance in advanced prostate cancer.
We're talking about metastatic castration-resistant prostate cancer, mCRPC. And this is one of the toughest challenges in solid tumor oncology.
Right.
Once the cancer progresses past those initial hormone therapies, when it learns how to survive without testosterone, it becomes highly aggressive.
And just notoriously difficult to treat effectively in the long run.
Exactly.
Absolutely. And looking at the stack of sources from the November 2025 clinical announcements, it paints a very clear picture of a strategic shift. The theme isn't just incremental improvement anymore, it's synergy.
That's right. Researchers are moving past single targets. They're going toward combination therapies, multispecific drugs, and really complex strategies.
It seems like they're designed not just to kill cancer cells, but to, what? Overcome the tumor's own defensive fortress.
That is the critical takeaway.
Mhm.
The cancer's defense mechanisms, its ability to evolve, to suppress the immune system, to hide, they're now being attacked head-on.
So we're seeing these amazing molecules engineered to bind 3 different targets at once.
Right, and treatments designed to fundamentally change the whole biological landscape of the tumor, the microenvironment itself.
So our mission today is to unpack 4 distinct novel approaches. These are all just entering phase 1 or 2 trials, and we're focusing on how they aim to defeat that resistance.
That's good.
Okay, let's start this deep dive with the molecular engineering breakthroughs, the trispecific immune engagers. When we talk about engineering immune cells to hunt cancer, trispecifics just sound like the next evolution.
They really are.
We've got 2 great examples here. One focuses on natural killer cells and the other on T cells. Let's start with GTB-5550 and its focus on those NK cells.
So GTB-5550 is, it's groundbreaking because it's a novel trispecific natural killer cell engager.
And that term, trispecific, is key.
It's crucial. It means it's doing 3 things at the exact same time to make sure that NK cell can succeed against a solid tumor, which is historically very difficult terrain for immune cells.
Okay, walk us through those 3 targets. And more importantly, what does each one do?
Okay, so the first target is B7H3. Think of it as a homing beacon that's heavily expressed on a lot of aggressive tumors, including prostate cancer.
Got it. Beacon.
The second is CD16, which is on the surface of the NK cell itself. That's the anchor point. It physically locks the immune cell onto the tumor.
And the third one, this is the interesting part.
This is the critical third element. It delivers an IL-15 signal.
So why is that IL-15 signal so vital? I mean, isn't just pointing the NK cell at the tumor enough?
You'd think so, but it's not. In the tumor microenvironment, especially in mCRPC, NK cells are often just exhausted or dysfunctional.
Yeah.
The whole environment is flooded with these immunosuppressive factors.
Yeah.
So IL-15 acts like a powerful cytokine. It's essentially a fuel injection.
The survival signal.
A survival signal, exactly. It boosts the NK cell's killing power and its ability to survive right when it's needed most.
So it's designed to overcome the cancer's ability to put the immune system to sleep.
Precisely. And the preclinical studies really back this up. GTB-5550 showed a strong ability to kill tumor cells even under really tough conditions like hypoxia.
Low oxygen.
Right, low oxygen environments.
Yeah.
And also in the presence of MDSCs.
MDSC is myeloid-derived suppressor cells. For our listeners, what role do those play?
Think of them as the tumor's own little immune police force. They're cells recruited by the tumor to actively shut down T cells and NK cells.
So they provide cover for the cancer.
They do. And this drug's mechanism seems robust enough to just push right past that suppression. And it's moving quickly. The first patient enrollment is forecasted for April 2026.
Wow. Okay, let's pivot now to MK6070. It keeps that trispecific design but swaps out the NK cell for a T cell.
Correct. MK6070 is a T cell engager. It targets DLL3, which is a protein you see a lot in neuroendocrine prostate cancer, or NEPC.
And small cell lung cancer too, right? Both really aggressive.
Both highly aggressive forms. And it activates the T cell through the common CD3 target.
But what's really fascinating to me here is the third target. It's serum albumin. Why on earth would you tie your cancer killer to a common blood protein?
It's a brilliant pharmacological move, really. By binding to serum albumin, the molecule gets protected from being cleared out too quickly by the kidneys.
Ah, so it extends its half-life. It stays in the body longer.
Significantly longer. And what that means for the patient is potentially less frequent dosing.
Which improves quality of life during a really tough treatment course.
Massively. It shows they're thinking about the patient experience, not just the cellular kill rate.
And MK6070 is already in phase 12 trials. What's the most compelling finding so far?
For me, it's the phenomenon they call the bystander effect.
The bystander effect. Okay.
We know tumors are heterogeneous, right? Not every single cell will have that DLL3 target. But lab studies showed MK6070 could kill neighboring tumor cells that lacked the target.
How does that work?
When the T cells attack the DLL3 positive cells, they release local cytokines, these inflammatory signals, that trigger a whole immune cascade right there, damaging and destroying the cells around them, whether they have DLL3 or not.
That is vital because that heterogeneity is one of the biggest reasons cancer comes back. So a mechanism that hits the target and its neighbors is a huge step forward.
Okay, so we've seen how engineers are building better immune recruiters. Now let's pivot to combining a physical attack with an immune boost. The Keynote G28 trial is pairing two very different modalities.
Yes, this is a phase 1 trial combining lutetium-177 DGOL radioligand therapy with pembrolizumab or Keytruda.
Which is a powerful PD-1 checkpoint blocker.
Right. And the group they're studying is mCRPC patients who have progressed after their initial hormone therapy, but, and this is key, they have not yet received chemotherapy.
So they're looking for that synergy before chemo even starts. Exactly.
This idea of combining internal radiation with immunotherapy, it's becoming more and more popular. So how exactly does that radioactive attack prime the immune system for the Keytruda boost?
The mechanism is called immunogenic cell death. The 177 LU-DGUL, it targets PSMA on the tumor cells and delivers its radiation payload.
Okay.
And when that radiation destroys the cell's DNA, the cell doesn't just die silently, it bursts, it explodes, releasing these damage-associated molecular patterns.
The alarm.
DAMPs.
The alarm bell.
Precisely. Those DAMPs get picked up by local immune cells, and it essentially teaches the immune system this is what cancer looks like, and it's dangerous.
And what primes the environment?
It primes the tumor microenvironment for T-cell recognition. Then Keytruda, the PD-1 blocker, comes in and releases the handbrake, preventing the tumor from shutting down those newly activated T-cells.
It's an elegant system, but with radioligand therapy becoming more common, we have Pluvicto already, how do we deal with the tumor developing resistance by losing its PSMA target? Doesn't that limit the DGUL component here?
That is the core challenge for all PSMA-targeted therapies, you're right. And it's why these combinations are so key. But the Keynote G28 trial is using a DGUL specifically, which has a pretty distinct advantage over its competitors.
Tell us about DGUL's edge. What makes it different?
Well, DGUL has a compact thiourea linker in its structure.
In layman's terms.
In layman's terms, this linker changes how the drug behaves in the body, makes it a bit more hydrophobic or water repelling.
Okay.
And that structural change significantly cuts down on kidney exposure because less of the drug is absorbed by the renal tissue.
So better clearance means potentially dodging some of those common side effects we see, like the salivary gland and kidney toxicity.
That's the hope, and it's the design rationale. And what's important is the single-agent data for DGUL already looked really strong.
What did it show?
In a prior phase 2 monotherapy trial, it posted a 35.9% confirmed tumor response rate by standard imaging and an incredible 81% response by PT criteria. That's already exceeding some benchmarks and suggests it's a powerful system ready for this immune combination.
We've spent a good amount of time on the immune system. Now let's look at the internal structural reasons why tumors resist and how 3 novel trials are attacking these foundational pathways. This category is truly fascinating.
Absolutely. When mCRPC resists hormone therapy, it often undergoes this cellular transformation. It adapts this aggressive phenotype that can look a lot like neuroendocrine cancer.
And the first strategy attacks that directly through epigenetics.
Right, the combination of Valemetostat and Darolutamide.
So what cellular machinery are they targeting to stop that transformation?
They're targeting a pathway governed by EZH2 overexpression. EZH2 is an epigenetic regulator.
So it's basically flipping genes on or off.
Exactly. And when EZH2 is overactive, it flips the switch that allows cancer cells to adopt that highly resistant neuroendocrine phenotype.
And Valemetostat is the EZH inhibitor. The sources specifically call it a dual EZH12 inhibitor. Why is hitting both EZH1 and EZH2 so critical?
Think of EZH2 as the main water valve the cancer uses to survive. If you only block that one, the cancer cells are smart. They can often immediately compensate by just opening up a secondary bypass valve, which is EZH1.
I see.
So dual inhibition, hitting both at the same time, prevents that compensation. And they're pairing that dual blockade with darolutamide, a powerful AR antagonist, so they're hitting both the core pathway and the escape mechanism.
And this phase 12 trial emphasizes precision oncology, right? With mandatory tumor biopsies.
Correct. They aren't just guessing. They need to confirm that EZH2 is actually driving the resistance in that specific patient before they enroll them.
Making sure the drug goes where it has the best chance of success. Now, strategy B is maybe the most indirect approach we've seen, targeting the environment, not the cell itself. This is the Fasudil trial.
Yes, a phase 2 trial of Fasudil hydrochloride plus a PD-1 checkpoint inhibitor. Fasudil is a ROCK inhibitor. Its job here is not to kill the tumor, but to fix the dysfunctional environment around it.
How does it do that?
Solid tumors create these chaotic, leaky blood vessels. This means poor blood flow, low oxygen, and it creates a physical barrier that stops T cells from getting into the tumor core.
We call those cold tumors immunologically barren.
Precisely. Fasudil normalizes those dysfunctional blood vessels. It lets oxygen in, relieving the hypoxia, and, critically, it enhances the delivery and infiltration of T cells.
So you turn that cold tumor hot, and then it becomes susceptible to the PD-1 blockade.
You've got it.
But wait, doesn't better blood flow also mean better nutrient delivery to the cancer? Is there a risk that normalizing the vessels could actually feed the tumor?
That's a very thoughtful question, and it speaks to the complexity of the microenvironment. While it's theoretically possible, the evidence strongly suggests that removing the barriers to immune cell infiltration is the overriding factor.
So the benefit of getting the T cells in outweighs any potential downside.
It seems to. You absolutely need the T cells to access the tumor for the PD-1 blocker to work, and Fasudil is the key that unlocks that door.
And our final strategy brings us back to multi-targeting, but with an antibody-drug conjugate, Gensci 143.
This is a bispecific ADC. It's the ultimate Trojan horse, engineered to target both B7H3 and PSMA simultaneously.
So if a tumor has both B7H3 positive cells and PSMA positive cells, this hits both.
That's the rationale. Remember the heterogeneity problem.
Right.
This is designed specifically to overcome it. By hitting two validated targets at once, the probability of cancer cells escaping treatment is significantly lowered.
And that phase 1 dose escalation study is set to start soon.
By the end of December, yes. So we should be seeing initial safety data on this dual targeting approach pretty soon.
This has been an incredibly dense but really encouraging dive into the future of mCRPC treatment. The big takeaway is clearly synergy and precision.
Absolutely. The days of single target treatments are, well, they're fading. We're moving toward these incredibly complex, multi-pronged approaches.
From the trispecifics like GTB5550 and MK6070
to combination attacks, like 177 low DGUL with Keytruda, and these foundational resistance strategies like EZH12 inhibition and vascular normalization.
It's all about addressing the tumor's ability to evolve and suppress the immune system at the same time.
And that offers significant hope where traditional therapies often fail. Which, it raises an important question.
Right. Given the sheer number of novel trials we talked about today that are now targeting B7H3 from that GTB5550 NK engager to the Gensci 143 dual ADC, how quickly will this specific antigen become the next major standard target in oncology, comparable to how ubiquitous PSMA is today?
That's the big question, isn't it? Something for all of us to track very closely as this data matures over the next few years.
Well, thank you for joining us for this deep dive into the absolute cutting edge of cancer research.
Stay strong and fight on.